wonder if we all say "what the fuck" every time that happens. That's simultaneously.
All right, you guys ready to rock? So, pulse oximetry, what does it measure?
Oxygen saturation, oxygen in the blood.
Okay. If we get down to the nitty gritty, it's not, remember, it's not measuring how much oxygen is attached to your hemoglobin. It's just measuring how much hemoglobin or the percentage of hemoglobin that has something attached to it, right? Your pulse oximeter does not have the ability to differentiate oxygen from carbon monoxide. It doesn't have the ability to differentiate from hydrogen cyanide, hydrogen sulfide. It just has the ability to register based upon the amount of light that is reflected from that red light, how much of that hemoglobin in one cell is saturated, which is what gives us that percentage, right? So the percentage of hemoglobin saturation is technically the most specific description of pulse oximetry. All right, let's go. There you go, Mike. I get everybody here. We've lost a few soldiers here. Everyone okay with the GCS? How we can measure GCS?
Yeah.
Yeah.
Good. Inotropic, what's inotropic? That's the what? The squeeze of the myocardium. Chronotropic is what? The rate. And dromotropic is the excitability of the myocytes and pacemaker cells. So if I have a positive chronotropic effect, my heart rate goes up. Negative chronotropic effect, my heart rate goes down. Positive inotropic, my squeeze improves. My injection fraction improves. My stroke volume improves. Negative inotropic effect, on the contrary. Okay, what's an ACE inhibitor?
Isn't it like blood pressure medicine?
Yes, and how is it blood pressure medicine?
So,
Works on the kidneys and the loop of Henle.
Ooh, no.
No?
It
It
prevents.
works on the back side of the Henle.
Angio2.
There we go, right? Remember, your angiotensin converting enzyme is what converts angiotensin 1 to angiotensin 2. And if I have angiotensin 2, I'm able to produce aldosterone, okay, which will increase blood pressure. So by taking an ACE inhibitor, right, I prevent the production of angiotensin 2, which means I inhibit the ability to produce aldosterone, which means in return, I will lose a contributing factor to the increase of systemic vascular resistance, which means my blood pressure will in return go down. So ACE inhibitors are really, really popular for blood pressure management, especially in our realm in the fire service, because it doesn't inhibit, right, like a beta blocker, some of your major compensatory mechanisms, right? It just inhibits one of the factors that can increase pressure in the compensation phase. So ACE inhibitors lower blood pressure by the prevention of the production of angiotensin 2, which in return stops the production of aldosterone. So for those of you that are on this Zoom that are on ACE inhibitors, that is why your physician selected ACE inhibitors over other alternatives, because NFPA regulations prevent a lot of blood pressure medications. What helps to break down acetylcholine? Acetylcholinesterase, right? That really long word that kind of looks like acetylcholine. Acetylcholine is the primary hormone of which part of your nervous system?
vagus nerve.
Well,
Oh,
Parasympathetic.
Parasympathetic.
right,
yeah.
right.
you're working towards it. You were working towards it, right? So acetylcholinesterase is what essentially breaks down the acetylcholine, right? For those of you on, on the hazmat trucks, that's why we carry 2-PAM, right? 2-PAM is the addition to atropine. Atropine just blocks some of the effects of all that excessive acetylcholine that's being produced by the organophosphate or even the carbamate. But the 2-PAM is what helps to produce that acetylcholinesterase that helps to combat all the excessive acetylcholine that's being released by the organophosphate. Breaking down your dopamine, right? At 2 to 5 mics per kilo per minute, what improves?
Kidney function.
Okay. And then when we get into 10 to 15 or 5 to 10, excuse me, what begins
Beta
to
1
improve?
effects.
What's that?
Beta 1 effects.
Okay. And then when we get into 10 to 20, we start to get
Vasoconstriction.
the vasoconstriction. Good. Very good. Patients on beta blockers, what may happen as an adverse event? Remember, there's beta receptors in the heart and in the lungs, right? So patients that are on beta blocker, especially non-selective beta blockers, they may actually also get bronchospasms because the beta 2 receptor sites are being antagonized. If a patient takes too much beta blocker and they have subsequent bradycardia, how do we manage that?
Atropine.
We'll try atropine, and atropine doesn't work. Then what?
We can do epi.
Even before epi, what's the direct antidote to a beta blocker overdose?
Oh.
Is it calcium chloride?
Nope.
Mag?
No. Direct antidote. It's glucagon. Remember, 3 to 5 milligrams IV glucagon, because glucagon is known to increase inotropy and chronotropic effects without using the beta receptor sites. So it's not necessary. It's not getting rid of the beta blocker, right? But it's able to increase inotropy and chronotropy without activating a beta receptor site. So by giving epinephrine still needs to utilize those beta receptor sites to produce the increase in inotropy and chronotropy, but the patient has overdosed on a beta blocker. So glucagon uses an alternative route, an alternative mechanism to increase inotropy and chronotropy. So beta blocker overdoses, we give glucagon at 3 to 5 milligrams.
So with a beta blocker, it's just slowing down the AV node, right? Allowing electricity to go down through.
No, a beta blocker is antagonizing your beta receptors in your heart, your beta 1 receptors in your heart. So it's inhibiting, the basic catecholamines from increasing your heart rate and increasing the efficacy of your heart.
So the speed that it goes down through, right? That's a chronotropic.
Okay. Yes.
I know I'm looking at it a different way. Sorry. So,
There's beta receptors encompassing your entire myocardium, right?
right.
And when a patient takes too much beta blocker, essentially, and even sitting here right now, your catecholamines are influencing your ability to maintain a normal heart rate, a normal cardiac output. Okay. If I take too much beta blockers, I know I begin to inhibit the ability for my body to maintain normal hemodynamics. So subsequently, their heart rate is going to begin to drop. Their ejection fraction is going to begin to drop. So they're going to start to suffer from bradycardia and potential hypotension as well. So if I recognize that it's because, hey, Jerry's described atenolol, right? I may choose to start with glucagon to manage what is suspected to be a beta blocker overdose.
Just out of curiosity, is that going to take a long time to take effect?
So
Just like,
I've done it twice, and I will talk. The most recent, I did it with after I gave the 3 milligrams. The next 3 blood pressures, so you're talking over a 5 to 10 minute window, the trend was dramatically higher. I mean, it was quite rewarding to see the rapid improvement of their condition.
all right, I just didn't know if it took a long time, like
It's not the same. It's not working like it is when converting glycogen to glucose. The glucagon itself is going directly to the myocardium and increasing the inotropy and chronotropy. No different than the epinephrine goes right to the myocardium and rapidly increases the inotropy and chronotropy. When talking about medications and thinking about the safety of the medication, how do we describe the safety of a medication? What determines the safety of the medication? How safe that medicine is?
The therapeutic index.
Perfect. And how do we determine a therapeutic index?
the lethal dose.
So we have our toxic dose, medium toxic dose, and then we've got our medium effective dose, right? So what commonly produces the desired effect and what commonly produces adverse events, right? The range in between there, that's our therapeutic index. Medications with wide therapeutic index are very safe. Medications with narrow therapeutic index are dangerous. We have to be super hyper vigilant that we're dosing appropriately. So in your parasympathetic nervous system, the vagus nerve is the heavy hitter there, which releases your acetylcholine, right? And the acetylcholine goes where? Where does it act upon?
The nicotine receptors. Nicotonic receptors.
That's your acetylcholinesterase.
Muscarinic receptors.
Yeah, your acetylcholine goes to your muscarinic 2. And think about your medications we use in breathing problems, right? Your what? Your Atrovent. Your Atrovent is a type of acetylcholine, right? Or it's an anticholinergic, which is essentially inhibiting the acetylcholine from attaching to the muscarinic 2, right? Which is preventing the mucosal production. What's the big difference between a non-depolarizing and depolarizing paralytic?
You get the
Isn't it like the
vacillations.
twitching or whatever?
Exactly. Your non-depolarizing is not going to produce fasciculations when your depolarizing are. For depolarizing, we've got succinylcholine, or non-depolarizing, we have rocuronium, vecuronium, and pancuronium. If I've got a very fast atrial rate, what can I give to slow that down?
Cardism.
Correct. And what is cardism?
It's a is
In
it
a
a
channel
calcium
blocker.
It's a calcium channel blocker, right? Remember, your calcium channel blockers work on your atrium. Your sodium and potassium channel blockers work on your ventricles. So any fast heart rate that's originating in the atrium, calcium channel blockers are good choices. Any fast heart rate that's originating in your ventricles, your sodium and your potassium channel blockers are good choices. What's Toradol?
pain
Pain med.
medicine.
Okay, is it a pain med in the sense that it's an opiate?
No.
What is it?
Not anti-inflammatory.
It's what type of anti-inflammatory?
NSAID?
Yeah, we have two types that prevent inflammation. We have steroids and we've got non-steroids, right? So an example of a steroid would be your solumedrol, right? Your solumedrol is essentially a steroid in the sense where it'll prevent the inflammatory response, meaning it'll put blinders on so your immune system won't initiate the inflammatory response. Your Toradol is a non-steroidal anti-inflammatory, so it inhibits or starts to slow inflammation, but it's not through the use of a steroid. Your NSAIDs are your over-the-counters, your that we buy from CVS, right? Your Toradol or your Ketorolac is a smooth muscle relaxer. It's also an NSAID. It does work extremely well, especially in renal calculi. Toradol's most common use is in renal calculi because of its smooth muscle and in the assistance with the inflammation that's produced by that grinding of that fucking sharp rock that's moving through your urethra or wherever the renal calculi exists, depending upon how far it's progressed. For those of you that have had a kidney stone, you know what I'm talking about. When talking about an action potential, you've got our relative and an absolute refractory period. What portion of the action potential is our absolute refractory period?
And they're like 0 through 3.
Yeah, it's the middle.
Like halfway through 3.
It's halfway through 0 to the halfway through 3, right? And that's super important. And we know the absolute refractory period because it's indicated by the R wave, right, in our QRS. We know that's right in the middle of phase 0 to phase 3. We know it's within the absolute refractory period, which is why when we sync our monitor, it identifies that R wave. How does TXA help in our trauma patients?
Stops bleeding.
All right, it doesn't stop bleeding.
Oh.
It kind
It
of
helps clot.
Yeah, it creates hyperfibrinolysis, right? It helps to produce fibrin that helps it to produce clotting. All right, so hypertonic solutions, let's say I've got a bag, right, that I'm about to give intravenously. In that bag, it's identified as a hypertonic solution because it's greater than 0.9%, right? Sodium chloride, okay? And that bag has a higher ion concentration than of what the serum value is in that intravascular space, right? The bag out here has a higher osmolarity than what's in my blood right now, right? So when I administer that volume from that bag into the blood, it's going to drag, right, or pull the fluid from your interstitial, right, and from your intercellular into your intravascular compartment. When I say intravascular, I'm saying extracellular in the vessel. So the volume outside the cells in the vessel. So hypertonic solutions, all right, are going to pull the volume from the tissue, from the cells into the intravascular compartment. And one of the advantages of that is we can move swelling that way. And for an example, let's say I've got a patient with a traumatic brain injury, right? You know, they fall, whack their head, and their brain tissue begins to swell. If I give a hypertonic solution, for an example, mannitol, what that will do is start to pull that volume from that tissue into the intravascular compartment. And I can then get that excessive volume because now it's in the intravascular compartment. I can get it down to my kidneys and get rid of it. So just think about where that volume is going in relation. Is it moving into the intravascular compartment, right? Or is it moving from the intravascular compartment into the intracellular and an interstitial compartment or interstitial tissue?
Hey, Blum, I got to run, man. I appreciate you doing this. Thanks.
No problem, buddy. Appreciate you coming on.
See you guys. Take care.
Hey, Blum, you looking at the questions to our test?
What does it matter to you?
You could just share a screen with us. I'm just
Share
saying, help us
screen,
out.
yeah.
A little something. I mean, come on, man. I mean, you're a good-looking guy, but you're
Just
not what I want to be watching on my computer.
just sit there and be quiet.
Sit there and take it, huh? Yeah, it sounds like my wedding night.
So the IO space, right? We drill into the interosseous membrane. What is the interosseous membrane?
Isn't that the part of the bone that actually produces the red blood cells?
Okay, but what are the anatomical names that comprise the IO space?
Epithelial. I can't say it.
The epiphysis, the diaphysis, and
Thank
what?
you.
The epiphysis and the diaphysis, that's not the part that makes up where the IO is drilled into. That's the part of the long bone.
But it's between. That's what I'm trying to say. It's
Okay. Yes.
right when we trying to not give you the answer. I'll come back to it. I can't describe it without just giving you the answer. What's a virotral?
What?
What's a what?
What's a virotral?
You use it for a rapid push.
Definitely not.
Not rapid push, but the Puritrol, it's what, 60? Wow.
So this over here, this is a virotral
Oh man, yeah.
or a virotral. And what it essentially is this spike right here, this is what spikes your bag. So like a 500 bag, a liter bag, whatever the case may be. And in situations where I need to have specific or control of fluid administration, or let's say I want to mix a medication into a small volume of fluid, or I need to convert a 500 ml bag to a 100 ml bag, I can use a virotral. So I'll spike the bag, and then I'll open up my dial flow, and I can fill this container up to 150 mLs or 125 mLs, depending upon the size of the virotral. And then I can close off the flow from my bag. I can administer a med into this virotral here, and attached to it is a 60 drop set. So essentially, I can convert this 500 ml bag to a 100 ml bag, a 50 ml bag, and I can administer now, and I can be sure that I'm only going to give the amount of volume that I put into my virotral. The advantage, we generally can use this in pediatric fluid administration, or we can use it in medication. Like, let's say I need to administer a med over time and I don't have the appropriately sized bag, I can move it into a virotral. The downside, the problem is I only will have a 60 drop set, which a lot of our meds in 100 ml bags we give over 10 minutes. I need that 10 drop set to really do that. So the primary purpose of a virotral would be for fluid resuscitation in pediatrics, where I'm giving a specific amount of volume and I'm worried about overhydrating the child. I can use a virotral. How do we make push dose epi?
Take 10 cc syringe, push out 1 and push in 1 milligram. That gives you the
Whoa,
One
whoa,
in
whoa!
10,000.
Definitely not.
No?
Slow down, slow
or
down.
not milligram. My bad.
1 milliliter, right?
Milliliter.
Of
Yes,
crash
sir.
card epi, right?
Yes.
So I'm moving 1 ml of epi into 9 mLs of normal saline, right? And that will give me my what?
1 in 10,000.
My one, not 1 in 10,000, my 1 to 100,000, right? Because I diluted it 10 more times.
Okay.
My 1 ml of epi contains 100 micrograms of epi. So I've moved 100 mics, and now I have 100 mics into 10 mLs, which gives me a 10 mic per cc concentration. Give me some. What are 2 breathing patterns that we can see in patients with traumatic brain injuries?
The buoyant one.
Biot, yep. And what else?
I don't remember the other one.
Shane Stoke, right? What's the big difference between a biot pattern and a Shane Stoke pattern?
The biot has periods of apnea.
And it's also what? The big difference.
Very
Your
erratic.
Shane Stokes is that crescendo pattern, right? It speeds up, slows down, right? Stop, speeds up, slows down, stop. Your biot, that's an irregular pattern and with built-in apnea. So it's hard to keep track of. Your biot is a regular, there's no pattern to it. They speed up, they kind of slow down, they speed back up, boom, they're not breathing. So your diazepam and your midazolam, what are those?
Sedatives.
They are classified as what?
Aren't they seizure medicines?
They're benzodiazepines, right? They're benzos, and benzos can do a number of different things, right? Benzos can produce amnesia, make you forget. Benzos can sedate you. One thing benzos can increase your seizure threshold. One thing that benzos are not used for or not used as is as an analgesic, right? So for pain management. If someone has a traumatic injury, a benzo is not a first choice for pain management. We want to avoid using benzodiazepines in the form or for the use of analgesia, right? I'm not going to use benzo to take care of the pain. I will use an analgesic for pain that produces analgesia, right? Which is by occupying that opiate receptor, which helps to control pain. Do we hyperventilate patients?
Hyperoxygenate.
We hyperoxygenate. We don't ever hyperventilate. Good. What is a big problem with hyperventilating someone who's not breathing? Like we're not paying attention. We're squeezing that back too rapidly.
You can get build up in the stomach, airflow. I can't think of that.
All right, so we get excessive gastric distension, right? I agree with you there totally. But if I'm hyperventilating, correct? I am overexpanding these lungs, and I'm eventually going to be
CO2.
No, I'm gonna as I overexpand these lungs, I'm putting too much tidal volume in. I'm eventually going to begin to compress the inferior vena cava, and I'm going to decrease the venous return to my heart. So we don't. There's not a single situation where hyperventilation True hyperventilation is indicated. All right, guys, we got less than a minute. Hop off and then hop right back on.